Hyperaldosteronism refers to an endocrine disorder where the adrenal gland produces above normal levels of the hormone aldosterone. Now, there are two adrenal glands, one above each kidney, and each one has an inner layer called the medulla and an outer layer called the cortex, which is subdivided into three more layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The outermost layer is the zona glomerulosa, and it's full of cells that make the hormone aldosterone. Aldosterone is part of a hormone family, or axis, which work together and are called the renin-angiotensin-aldosterone system. Together, these hormones decrease potassium levels, increase sodium levels, and increase blood volume and blood pressure. Aldosterone is secreted in response to elevated levels of renin, and its role is to bind to receptors on two types of cells along the distal convoluted tubule of the nephron. First, it stimulates the sodium-potassium ion pumps of the principal cells to work even harder. These pumps drive potassium from the blood into the cells, and from there it flows down its concentration gradient into the tubule to be excreted as urine. At the same time, the pumps drive sodium in the opposite direction, from the cell into the blood, which allows more sodium to flow from the tubule into the cell, down its concentration gradient. Since water often flows with sodium through a process of osmosis, water also moves into the blood, which increases blood volume and therefore blood pressure. The other function of aldosterone is to stimulate the proton ATPase pumps in alpha intercalated cells, which causes more protons to get excreted into the urine. Meanwhile, ion exchangers on the basal surface of the cell move the negatively charged bicarbonate ion into the extracellular space, causing an increase in pH. Hyperaldosteronism can happen due to primary causes, which is where the adrenal gland itself is responsible for the excess production of aldosterone. The most common primary cause is called idiopathic hyperaldosteronism, because the zona glomerulosa has an increase in the number of cells secreting aldosterone, but it's not really clear why this happens. The second most common cause is called Conn syndrome, and this is where an adenoma or tumor in the glandular epithelial cells secrete too much aldosterone. A third cause is familial hyperaldosteronism, and this is a genetic condition that runs in families, and it's where the zona glomerulosa cells inappropriately make aldosterone in response to adrenocorticotropic hormone, which is secreted by the pituitary gland. And this is in addition to responding to renin as normal. Hyperaldosteronism can also be due to secondary causes, where the pathology lies outside the adrenal gland. Secondary causes of hyperaldosteronism are usually due to excess aldosterone production in response to high levels of renin. This might happen when there's a chronic decrease in blood pressure, like in congestive heart failure or cirrhosis. Hyperaldosteronism leads to hypokalemia, which is low potassium levels in the blood, as well as hypernatremia, high sodium levels in the blood. With more sodium around in the blood, water moves into the blood vessels, which results in a high blood volume and high blood pressure, or hypertension. Finally, the loss of protons also results in an alkalosis, and more specifically a metabolic alkalosis, since it's caused by the kidneys. Individuals with hyperaldosteronism typically develop hypertension-related symptoms, like headaches and facial flushing, as well as hypokalemia-related symptoms, like constipation, weakness, and potentially changes in their heart rhythm. The diagnosis of hyperaldosteronism is mainly done by measuring levels of renin and aldosterone. In primary hyperaldosteronism, the main problem is that the zona glomerulosa cells secrete high levels of aldosterone, and that aldosterone has a negative feedback effect on renin, and so it actually inhibits renin production. So in this case, aldosterone levels are high and renin levels are low. In secondary hyperaldosteronism, on the other hand, the main problem is that there's too much renin produced by the juxtaglomerular cells of the kidneys. So even though aldosterone's inhibiting renin secretion, renin production's still being stimulated by those cells. And this means that there's both high levels of aldosterone and high levels of renin. Treatment of hyperaldosteronism is usually with potassium-sparing diuretics, especially spironolactone, which competitively binds to aldosterone receptors on the principal and alpha intercalated cells. With these medications around, aldosterone can't exert its effects. Additionally, treating the underlying cause can also be helpful. For example, in Conn syndrome, surgical removal of the tumor can help, and also managing heart failure and cirrhosis. Alright, as a quick recap, hyperaldosteronism is the chronic excess secretion of aldosterone from the zona glomerulosa cells of the adrenal gland. And these high aldosterone levels can lead to hypokalemia, hypernatremia, hypertension, and a metabolic alkalosis. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Primary adrenal insufficiency is a rare endocrine disorder that happens when the adrenal gland isn't able to produce enough of the hormones that the body needs, particularly aldosterone and cortisol. The reason it's called primary is that the underlying problems localize to the adrenal gland itself, rather than a problem of a hormone that acts on the adrenal gland or elsewhere in the body. Primary adrenal insufficiency can develop acutely or chronically, and a really famous example of someone having this condition is John F. Kennedy, who was diagnosed at age 30. Now there are two adrenal glands, one above each kidney. And each one has an inner layer called the medulla and an outer layer called the cortex, which is subdivided into three more layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The outermost layer is the zona glomerulosa, and it's full of cells that make the hormone aldosterone. Aldosterone is part of a hormone family, or axis, which work together and are called the renin-angiotensin-aldosterone system. Together, these hormones decrease potassium levels, increase sodium levels, and increase blood volume and blood pressure. Aldosterone is secreted in response to elevated levels of renin, and its role is to bind to receptors on two types of cells along the distal convoluted tubule of the nephron. First, it stimulates the sodium-potassium ion pumps of the principal cells to work even harder. These pumps drive potassium from the blood into the cells, and from there it flows down its concentration gradient into the tubule to be excreted as urine. At the same time, the pumps drive sodium in the opposite direction, from the cell into the blood, which allows more sodium to flow from the tubule into the cell, down its concentration gradient. Since water often flows with sodium through a process of osmosis, water also moves into the blood, which increases blood volume and therefore blood pressure. The other function of aldosterone is to stimulate the proton ATPase pumps in alpha intercalated cells, which causes more protons to get excreted into the urine. Meanwhile, ion exchangers on the basal surface of the cell move the negatively charged bicarbonate ion into the extracellular space, causing an increase in pH. The middle layer of the adrenal gland is the zona fasciculata, and the cells there make the hormone cortisol, as well as other glucocorticoids. Cortisol is needed in times of emotional and physical stress, like arguing with a friend or fleeing from a pack of raccoons. In those situations, the hypothalamus, which is an almond-sized structure that sits at the base of the brain, releases corticotropin-releasing hormone, which is then received by the pituitary gland, the pea-sized structure sitting just under the hypothalamus. In response, the pituitary gland sends out adrenocorticotropic hormone, or ACTH, which travels through the blood to the zona fasciculata of the adrenal glands, and signals cells there to release cortisol. Cortisol is a lipid-soluble molecule, meaning it can mingle with fats, which allows it to easily pass through the plasma membrane of cells and bind to the receptors inside. In fact, almost every cell in the body has cortisol receptors, so it affects a huge variety of functions in the body. One of cortisol's main jobs, though, is to increase blood glucose levels by promoting gluconeogenesis in the liver. Gluconeogenesis is the formation of glucose from non-carbohydrate sources, like amino acids or free fatty acids. Cortisol also gets the muscles to break down proteins into amino acids and gets adipose tissues to break down fats into free fatty acids, both of which help provide the liver with more raw materials to work with. So basically, cortisol keeps blood glucose levels high, and this is in contrast to the hormone insulin, which causes glucose to be taken up by various body tissues. And so essentially, cortisol acts to counteract this effect in an effort to make sure that the body can respond appropriately to those raccoons or other stressors. Finally, the innermost layer is the zona reticularis, and the cells there make a group of sex hormones called androgens, including one called dihydroepiandrosterone, which is the precursor of testosterone. So the adrenal glands are involved in testosterone production in both men and women. But the amount that the adrenal glands actually contribute is pretty small, relative to the testes in men, which account for the very different levels of androgens in men versus women. In men, high levels of androgens are responsible for the development of male reproductive tissues and secondary sex characteristics like facial hair and a large larynx or Adam's apple. In women, low levels of testosterone are responsible for a growth spurt in development, underarm and pubic hair during puberty, and an increased sex drive in adulthood. The exact mechanism for adrenal androgen production isn't well understood, but like cortisol, it seems to be stimulated by adrenocorticotropic hormone released from the pituitary gland. So that all brings us back to primary adrenal insufficiency, where the adrenal cortex gets damaged. This can happen acutely or chronically. Acute primary adrenal insufficiency can arise from Waterhouse-Friderichsen syndrome, which is when a sudden increase in blood pressure causes blood vessels in the adrenal cortex to rupture, filling up the adrenal glands with blood and causing tissue ischemia and adrenal gland failure. Chronic primary adrenal insufficiency is also called Addison disease, and in high-income countries, the most common cause is autoimmune destruction. This is when the body's own immune cells mistakenly attack the healthy adrenal cortical tissues, though the precise reason why this happens isn't clear. In the rest of the world, the most common cause of Addison disease is tuberculosis. In this case, the infection spreads from the lungs to the adrenal glands, causing inflammation and destruction in the adrenal cortex. Another important cause is metastatic carcinoma, which is where cancer spreads to the adrenal cortex from somewhere else in the body. Regardless of the cause, it turns out that the adrenal cortex has a high functional reserve, meaning that a small amount of functional tissue can still do a pretty good job of churning out enough hormones to meet the body's needs. As a result of this, though, once there are symptoms, it's usually a sign that a majority, sometimes up to 90%, of the adrenal cortex has been destroyed. The symptoms of primary adrenal insufficiency correspond to which layers of the adrenal cortex have been destroyed. When the zona glomerulosa is destroyed, aldosterone levels fall, and that leads to high potassium levels in the blood, or hyperkalemia, and low sodium levels in the blood, or hyponatremia. With less sodium around in the blood, water moves out of the blood vessels, which results in a low blood volume, or hypovolemia. Finally, fewer protons are lost, meaning more build up in the blood, and that results in an acidosis, and more specifically a metabolic acidosis, since it's caused by the kidneys. These electrolyte changes in hypovolemia can cause symptoms like cravings for salty foods with simultaneous nausea and vomiting, fatigue, and dizziness that worsens with standing. When the zona fasciculata is destroyed, cortisol levels fall, and that leads to inadequate glucose levels during times of stress. This means that while being chased by a pack of raccoons, instead of feeling ready to sprint, a person might feel weak, tired, and disoriented. Also, those decreased levels of cortisol cause the pituitary gland to become overactive, since usually cortisol has a negative feedback effect on the pituitary gland. So it ends up producing pro-opiomelanocortin, which is a precursor to adrenocorticotropic hormone, but it also turns out to be a precursor to melanocyte-stimulating hormone, the hormone that leads to skin pigment production. So when your pituitary gland's overactive, it ends up making more melanocyte-stimulating hormone, resulting in hyperpigmentation, or darkening of the skin. especially in sun-exposed areas and joints, like the elbows, knees, and knuckles. In some extreme cases of primary adrenal insufficiency, the zona reticularis can be affected as well, and androgen levels can fall. This decrease doesn't affect men much, because remember that the testes are a major source of male androgens. Women, though, can experience a loss of pubic and armpit hair, as well as a decreased sex drive. Now, symptoms of acute primary adrenal insufficiency are usually severe and may include low blood pressure, vomiting, abdominal pain, fever, and mental status changes ranging from confusion to coma. In contrast, symptoms of chronic primary adrenal insufficiency are more insidious and nonspecific, like fatigue, anorexia and weight loss, weakness, abdominal pain, and muscle and joint pain. Oftentimes, these can go unnoticed until a major stressor, like a serious injury, surgery, or infection, suddenly causes the symptoms to become really severe. In other words, the body has a sudden increased need for aldosterone and cortisol, and the failing adrenal cortex simply can't deliver. This is known as adrenal or Addisonian crisis, and it usually happens when the majority of the zona glomerulosa and zona fasciculata are destroyed. It can cause a sudden pain in the lower back, abdomen, or legs, with severe vomiting and diarrhea, followed by dehydration, low blood pressure, and loss of consciousness. Left untreated, an Addisonian crisis can be fatal. Primary adrenal insufficiency can be diagnosed with an adrenocorticotropic hormone stimulation test. During the test, a small amount of synthetic adrenocorticotropic hormone is given, and the amount of cortisol and aldosterone produced in response is measured. And this helps you figure out how well the adrenal glands are working. Usually, individuals with primary adrenal insufficiency are treated with hormones to make up for the lack of cortisol, aldosterone, and androgens. They typically have to be taken for the rest of an individual's life, and stopping the hormone replacements can lead to Addisonian crisis. Alright, as a quick recap, primary adrenal insufficiency is a failure of the adrenal cortex, specifically the zona glomerulosa, which causes low aldosterone, as well as the zona fasciculata, which causes low cortisol, and in severe cases, the zona reticularis, which causes low androgens. It can be acute or chronic, in which case it's known as Addison disease. Waterhouse-Friderichsen syndrome happens when the blood vessels in the adrenal gland rupture during a severe bacterial infection, and this turns the adrenal glands into sacs of blood. This ends up resulting in adrenal crisis, or acute adrenal insufficiency, which is when the adrenal gland suddenly stops producing hormones. The syndrome is named after two physicians, Waterhouse and Friderichsen, who separately described the syndrome back in the early 1900s. Now, there are two adrenal glands, one above each kidney, and each one has an inner layer called the medulla and an outer layer called the cortex. The adrenal cortex is subdivided into three more layers: the zona glomerulosa, zona fasciculata, and zona reticularis. The adrenal cortex secretes hormones under the control of adrenocorticotropic hormone, released by the pituitary gland. The outermost layer is the zona glomerulosa, which makes the hormone aldosterone. Aldosterone acts on the nephrons of the kidney to decrease potassium levels, increase sodium levels, and increase blood volume and blood pressure. The middle layer is the zona fasciculata, which makes the hormone cortisol, as well as other glucocorticoids. The main job of a glucocorticoid is to increase blood glucose levels, especially when there's emotional and physical stress. Finally, the innermost layer is the zona reticularis, which makes a group of sex hormones called androgens. In men, androgens stimulate the development of male reproductive tissues and secondary sex characteristics, like facial hair and a large Adam's apple. In women, androgens cause a growth spurt and growth of underarm and pubic hair during puberty. Now, the adrenal gland gets blood through three main arteries: the superior, middle, and inferior suprarenal arteries. All three divide into branches that supply the adrenal cortex and the adrenal medulla. After delivering oxygen to those tissues, the blood starts to collect again in the medullary vein and eventually into the suprarenal vein. The root cause of Waterhouse-Friderichsen syndrome is severe bacterial infection, or sepsis. This sepsis is typically due to Neisseria meningitidis, which is a gram-negative bacteria that's best known for causing meningitis. Other bacteria that can cause Waterhouse-Friderichsen syndrome include Pseudomonas aeruginosa and Haemophilus influenzae. The outer membrane of these bacteria has endotoxins, which are large and clunky lipopolysaccharide molecules, or LPS. These LPS molecules directly damage endothelial cells of the blood vessels and cause them to release procoagulant-like tissue factor, which promotes blood clot formation within blood vessels. When that happens during an infection, bacteria can start growing in these clots, forming septic emboli, which can drift away and get lodged within other blood vessels. The procoagulants also trigger disseminated intravascular coagulation, or DIC, which is when there's extensive clotting in blood vessels throughout the body, and it quickly consumes platelets and clotting factors. Without enough platelets circulating in the blood, other parts of the body start to bleed with even the slightest damage to the blood vessel walls. In Waterhouse-Friderichsen syndrome, this chain of events can happen and a septic embolus can get lodged in a small blood vessel in the adrenal gland. This can cause pressure in the vessel to increase, stretching the blood vessel walls and potentially making the blood vessel rupture. When a vessel breaks, the DIC makes it hard to form clots, and a lot of blood starts to pool within the adrenal gland. That big pool of blood sitting within the confined space of the adrenal gland increases the local pressure, and that pressure pinches shut the nearby blood vessels. This results in ischemia and eventually necrosis of the various hormone-producing cells in the adrenal gland. Waterhouse-Friderichsen syndrome results in Addisonian crisis, which is when both the adrenal glands suddenly stop producing hormones, especially aldosterone and cortisol. Left untreated, an Addisonian crisis can be fatal. Now, a characteristic symptom seen in Waterhouse-Friderichsen syndrome caused by Neisseria meningitidis is a petechial rash throughout the body, which fuses together to form large purpura over time. Addisonian crisis can cause sudden pain in the lower back, abdomen, or legs, as well as severe vomiting and diarrhea, low blood pressure, and eventually a loss of consciousness. Other symptoms include fever and chills due to the sepsis. Diagnosis of Waterhouse-Friderichsen syndrome starts with measuring the amount of cortisol and aldosterone produced after giving adrenocorticotropic hormone, and this normally increases adrenal hormone production. A blood culture can also be done to look for the bacteria, and imaging with ultrasound or CT scans usually shows collections of blood within the adrenal glands. Waterhouse-Friderichsen syndrome needs emergency treatment with antibiotics to fight the infection, and glucocorticoids to help support a person's metabolic needs and blood pressure. Supplementary hormones typically have to be taken for the rest of an individual's life. Alright, as a quick recap. In Waterhouse-Friderichsen syndrome, there's often a combination of a serious bacterial infection, often Neisseria meningitidis, which leads to disseminated intravascular coagulation. Tiny blood vessels in the adrenal glands can break, turning the adrenal glands into sacs of blood. Adrenal tissue dies due to tissue necrosis and is unable to produce hormones. And all this leads to an Addisonian crisis, which can be severe if not diagnosed early and treated with antibiotics and glucocorticoids.
Congenital anomalies appear as the baby develops in utero and vary in severity and presentation, ultimately impacting the infant's health, development, and survival. We can talk about some of the more common and severe defects, beginning with the head and then making our way down the body. Cleft lip, esophageal atresia, congenital diaphragmatic hernia, gastroschisis, omphalocele, biliary atresia, bladder exstrophy, and open neural tube defects. So first, a cleft lip is when the individual's upper lip doesn't form completely and has an opening in it. It's usually associated with a cleft palate, which is when the palate doesn't form completely and has an opening in it. Now, these defects can occur as isolated malformations or as part of a syndrome involving multiple other organs, including the heart. Regarding prenatal diagnosis, cleft lip can be diagnosed with accuracy via ultrasound after 13 or 14 weeks of gestation. Ultrasound images in the coronal view and axial planes can help see the fetal lip and palate and assess if there are associated abnormalities, like lower limbs or vertebral column defects. After birth, diagnosis is clinical. Early management is mostly supportive, and it aims to help the baby eat. It can be done with devices like specialty designed bottle nipples, dental appliances, a feeder that can be squeezed to deliver formula, and an artificial palate molded to the individual's own palate. However, surgical closure is the definitive treatment. For a cleft palate, a two-stage procedure is often done. First, the cleft lip, nose, and soft palate are repaired at age 3 to 6 months. Then, the residual hard palate cleft is repaired at age 15 to 18 months. Esophageal atresia is a birth defect resulting in an interrupted esophagus. This way, the esophagus has two separate sections, an upper and lower esophagus, that do not connect. One or more fistulas between the esophagus and trachea may also occur. Prenatal diagnosis is rare, but it can be suspected on an ultrasound that detects polyhydramnios and an absent or small stomach in the second or third trimester. After birth, clinically, the newborn chokes or vomits most or all of the food they consume. Next, if esophageal atresia is suspected, a gastric tube is inserted in the infant's nose or mouth. If it cannot pass down into the stomach, diagnosis is confirmed, and an X-ray is needed to assess the location of the obstruction. Treatment consists of surgery to remove the obstruction and reconnect the two segments of the esophagus. If present, any fistula will also need to be ligated. Third, congenital diaphragmatic hernia is due to absent or abnormal fusion of the pleural peritoneal folds during the formation of the diaphragm. This causes the organs in the abdomen to slip into the chest. Around half of the cases have associated anomalies, most commonly cardiac, urogenital, and musculoskeletal. Now, because usually herniation occurs on the left, the lung on the affected side doesn't develop as it should, and it becomes hypoplastic. Diagnosis for congenital diaphragmatic hernias is prenatally done by ultrasound. Left-sided defects are characterized by the presence of the small bowel in the left chest, which is distinguished from other lesions by its peristalsis and fluid content. The fluid-filled stomach may be absent from the abdomen, and it might be displaced into the lower thorax next to the left heart. A portion of the liver may be herniated as well, appearing as a homogeneous dark mass in the chest. Postnatal diagnostic evaluation begins with a clinical examination. Because the lung is underdeveloped, after birth, newborns will mostly present respiratory distress, usually within the first hours of birth. Other common findings include a barrel-shaped chest, a scaphoid or boat-appearing abdomen, since the abdominal contents migrate into the chest, and absence of breath sounds on the affected side. More often than not, the heartbeat is displaced to the right because of a shift in the mediastinum. Next, diagnosis is confirmed by chest radiography, showing herniation of the bowels into the hemithorax with little or no lung on the affected side. Other radiographic findings include displacement of medial steinal organs, like the heart on the opposite side, compression of the healthy lung, and a small abdomen with no visible bowel. In the rare instances when the defect is right-sided, the liver may be the only herniated organ and will appear as a large thoracic mass. Postnatal management can be divided into two parts. Preoperative medical management consists of correcting the individual's oxygenation, blood pressure, and acid-base status if these are disturbed. Acidosis and hypoxia increase the risk of pulmonary hypertension. Hypotension increases the risk of right to left shunting that contributes to hypoxia. And the second part consists of surgical repair, which includes closure of the diaphragmatic defect and reduction of the viscera into the abdominal cavity. Next, gastroschisis is an abdominal wall defect through which the bowel, and sometimes other abdominal organs, slips outside the abdomen. Prenatal diagnosis can be made by maternal serum alpha fetal protein assessment and ultrasound by 12 weeks of gestation. On ultrasound examination, gastroschisis appears located to the right of the umbilical cord insertion site and tends to be under 4 centimeters in diameter. Sometimes, when the bowels herniate, it can compromise the mesenteric blood supply, which, combined with the exposure to the toxic environment of the amniotic fluid, leads to bowel wall inflammation and decreased bowel motility. The stomach is usually in the wrong position, even when intra-abdominal. The eviscerated intestinal loops lack a covering membrane and float freely in the amniotic fluid. Oligohydramnios is the most common amniotic fluid abnormality, but polyhydramnios may occur, particularly in those with reduced bowel motility or obstruction. After birth, the diagnosis is clinical, and it's based on the exteriorization of the bowels through the midline defect and on the absence of the covering membrane. Treatment begins with delivery room care. Neonatal fluid and heat losses are 2.5 times that of a healthy newborn, and it only increases when the bowels are exposed. This is why covering the bowels with sterile saline dressings and wrapping them with plastic wrap is mandatory. Next, fluids and broad-spectrum antibiotics that cover maternal vaginal flora, like ampicillin and gentamicin, are also needed to prevent infection. Additional steps include inserting an oral gastric tube to decompress the stomach and providing respiratory support if required. The defect must then be closed via surgery, which can be difficult if the defect is large and other abdominal organs are also herniated. However, the prognosis is generally very good. Okay, fourth, omphalocele is also a midline abdominal wall defect through which abdominal contents eviscerate. However, omphalocele is covered by a membrane of amnion and peritoneum, with an additional layer of Wharton's jelly between those two. The defect occurs at the base of the umbilical cord, with the cord and umbilical vessels inserting at the apex of the omphalocele sac. Prenatal diagnosis is possible through ultrasound by the end of the first trimester. Ultrasonography can also categorize omphaloceles as either non-liver containing or liver containing. The location of the liver is important because non-liver containing omphaloceles are commonly associated with fetal aneuploidy, which is when individuals have an abnormal number of chromosomes, while liver containing omphaloceles are usually isolated findings. Postnatal diagnosis is based on the characteristic clinical finding of an anterior midline abdominal mass with a covering membrane at the site of cord insertion, although the covering membrane may be difficult to see or it might be ruptured. Management begins with supportive care, which consists of sterile wrapping of the bowel to preserve heat and minimize insensible fluid loss, insertion of an oral gastric tube to decompress the stomach, and intubation if necessary. Surgery is then needed to repair the defect. Small defects, 2 to 3 centimeters, can be repaired in the first 24 to 72 hours of life by primary closure of both fascia and skin. The remaining spectrum of defects usually involve a silo, which is a type of bowel bag that can be progressively reduced. This is done to delay surgery. Okay, so fifth is biliary atresia. It's a progressive fibroobliterative disease of the extrahepatic biliary tree that leads to biliary obstruction and neonatal jaundice. Prenatally, biliary atresia can be suspected on ultrasound. Signs that point to this condition include absent or abnormal gallbladder in the second trimester or the presence of the triangular cord sign, which is a thick, tubular, or triangular echogenic density along the anterior aspect of the portal vein. After birth, evaluation begins with clinical examination. Typically, individuals are born without jaundice, but within the first 2 months of life, jaundice develops and stools become progressively discolored. The onset of jaundice occurs at any time from birth up to 8 weeks of age, and it's unlikely to appear later. Most infants also have dark urine because of bilirubin excretion into the urine. If jaundice has gone unnoticed and the disease has progressed, there may be a firm, enlarged liver and splenomegaly. Okay, so next, laboratory evaluation begins with blood tests to assess hepatic function and rule out other etiologies. Usual findings include elevations in direct bilirubin, more than 0.5 milligrams per deciliter, conjugated bilirubin, 0.3 milligrams per deciliter, and mild elevations in serum aminotransferases, with a disproportionate increase in gamma glutamyl transpeptidase levels. Next, an abdominal ultrasound is needed to exclude other anatomic causes of cholestasis, like a choledochal cyst. Typically, in biliary atresia, the gallbladder is either absent or irregular in shape. Additional features to support the diagnosis include abnormal gallbladder size and shape, the triangular cord sign, gallbladder contractility, and absence of the common bile duct. Okay, so the patency of the extrahepatic biliary tree can be further assessed by hepatobiliary scintigraphy. If the tracer is not excreted into the bowel, biliary atresia is suspected, but does not exclude other diseases. Conversely, if scintigraphy shows the tracer is excreted from the liver to the small bowel, it means the tree is not obstructed and biliary atresia is very unlikely. Next, liver biopsy is performed in all infants with suspected biliary atresia for two reasons. One purpose is to identify histologic changes consistent with obstruction that warrant surgical exploration. The other is to differentiate the condition from other causes of intrahepatic cholestasis, which would not need surgical exploration. Characteristic histologic features of biliary atresia include expanded portal tracts with bile duct proliferation, portal tract edema, fibrosis and inflammation, and canicular and bile duct bile plugs. Histologic findings alone cannot help to distinguish biliary atresia from other causes of obstruction, so if there's evidence of obstruction, imaging is required. An intraoperative cholangiogram is considered the gold standard. Biliary atresia diagnosis is confirmed if during the intrahepatic cholangiogram, the contrast does not fill the biliary tree or reach the intestine. Treatment consists of hepatoportal enterostomy, the Kasai procedure. This operation is undertaken in the attempt to restore bile flow from the liver to the proximal small bowel. For this procedure, a loop of bowel is created by the surgeon and directly anastomosed to the hilum of the liver, following excision of the biliary remnant. Sixth, bladder exstrophy is a complex congenital anomaly involving the musculoskeletal system and the urinary, reproductive, and intestinal tracts. In exstrophy, there's a failure of midline closure from the umbilicus to the perineum. As a result, the inside of the bladder pokes outside the belly, and instead of its normal round shape, the bladder's flat. Moreover, the bladder is open suprapubically, and urine drips from the open bladder rather than through the urethra. This condition is associated with separation of the pubic symphysis and epispadias, or bifid genitalia. Prenatal diagnosis on ultrasound is usually based on absent bladder filling, a low-set umbilicus, pubic bone separation, small genitalia for gestational age, and a lower abdominal mass that increases in size as the pregnancy progresses. When suspicion is high but ultrasound inconclusive, bladder exstrophy may be confirmed by MRI. If prenatal diagnosis is not possible, after birth, the diagnosis of bladder exstrophy is made clinically. Regarding treatment, the exposed bladder is irrigated and a non-adherent film is placed to prevent contamination. Reconstructive surgery follows soon after that. The goals are to provide enough space for urine storage, create outer sex organs that look and function acceptably, establish bladder control, and preserve kidney function. And finally, neural tube defects, or NTDs, are relatively common congenital anomalies that develop when a portion of the neural tube, the precursor to the central nervous system, fails to close as it should during the 5th and 6th weeks of gestation. The resulting defect may involve the vertebra, spinal cord, cranium, or brain. NTDs are mostly open, meaning the defect is only covered by a membrane and not skin. Examples include myelomeningocele, or spina bifida, where the spine is not closed, meningocele, which is a protrusion of the meninges combined with an accumulation of cerebral spinal fluid outside the vertebral canal, encephalocele, a sac-like protrusion and projection of the brain and the membranes that cover it through an opening in the skull, and anencephaly, which is when a major portion of the brain, skull, and scalp is missing. Closed NTDs are covered by skin, and examples include lipomyelomeningocele, characterized by fat tissue overgrowth in the spinal cord, and lipomeningocele, a meningocele associated with fat tissue. Prenatal diagnosis is comprised of two approaches: ultrasound examination or measurement of maternal serum alpha-fetoprotein. Ultrasound detects most of the defects and classifies them as open or closed. Alpha-fetoprotein, a fetal-specific globulin synthesized by the fetal yolk sac, gastrointestinal tract, and liver, is usually increased in the maternal serum, amniotic fluid, and fetal plasma. Serum testing is performed ideally at 16 to 18 weeks of gestation, and the results are expressed as multiples of the median for each gestational week. A value equal or above 2.0 or 2.5 multiples of the median is considered an abnormal result. Postnatally, diagnosis is clinical, but a series of other tests are required to detect any associated anomaly. On examination, oral clefts and musculoskeletal malformation are the most commonly observed associated anomalies. Echocardiography might detect heart defects like patent ductus arteriosus and atrioventricular septal defects. Those with neural tube defects are at increased risk of chromosomal abnormalities, especially if other anomalies are present, so genetic testing might also be indicated. An MRI is needed to confirm uncertain ultrasound findings, better define the extent of the defect, and exclude central nervous system abnormalities. Treatment depends on the type and severity of the condition and on the presence of complications. Surgery aims to close the defect, although in some cases, like anencephaly, life expectancy is typically just past birth. Okay, a quick recap. A cleft lip is a congenital opening of the upper lip. It's usually associated with a cleft palate, which is when the palate doesn't form completely and has an opening in it. Prenatal diagnosis is established by ultrasound after 13 or 14 weeks of gestation. After birth, diagnosis is clinical. Early management is mostly supportive, while surgical closure is the definitive treatment. Esophageal atresia is a congenital obstruction of the esophagus. Prenatal diagnosis is rare, but it can be suspected on an ultrasound that detects polyhydramnios and an absent or small stomach in the second or third trimester. After birth, a gastric tube is inserted into the infant's nose or mouth. If it can't pass down into the stomach, diagnosis is confirmed, and an X-ray is needed to assess the location of the obstruction. Treatment consists of surgery to remove the obstruction and to ligate a fistula that might be present. Congenital diaphragmatic hernia is due to absent or abnormal fusion of the pleural peritoneal folds of the diaphragm, causing the organs in the abdomen to slip into the chest. Prenatally, it's diagnosed by ultrasound. Postnatally, it's confirmed by chest radiography, showing herniation of the bowels into the hemithorax. Postnatal management can be divided into supportive care and surgical repair. Next, gastroschisis is an abdominal wall defect through which the bowel and sometimes other abdominal organs slip outside the abdomen. Prenatal diagnosis can be made by routine ultrasound screening, as well as maternal serum alpha-fetoprotein assessment. After birth, clinical diagnosis is based on the exteriorization of the bowels through the midline defect and on the absence of the covering membrane. Treatment consists of covering the bowels with sterile saline dressings and wrapping them with the plastic wrap, broad-spectrum antibiotics, and surgery. Omphalocele is also a midline abdominal wall defect through which the abdominal contents eviscerate. Prenatal diagnosis is possible through ultrasound by the end of the first trimester. Postnatal diagnosis is based on the physical examination, showing the characteristic clinical finding of an anterior midline abdominal mass with a covering membrane at the site of cord insertion. Supportive care consists of sterile wrapping of the bowel to preserve heat and minimize insensible fluid loss, insertion of an oral gastric tube to decompress the stomach, and intubation if necessary. Surgery is then needed to repair the defect. Okay, so biliary atresia is a progressive fibro-obliterative disease of the extrahepatic biliary tree that leads to biliary obstruction and neonatal jaundice. Prenatally, biliary atresia can be suspected on ultrasound. After birth, diagnosis is based on an abdominal ultrasound, hepatobiliary scintigraphy, and sometimes liver biopsy. Diagnosis is then confirmed by intraoperative cholangiogram. Treatment consists of hepatoportal enterostomy, the Kasai procedure. In bladder exstrophy, there's failure of midline closure from the umbilicus to the perineum. As a result, the inside of the bladder pokes outside of the belly, urine drips from the open bladder, the pubic symphysis is separated, and the genitals are separated into two. Prenatal diagnosis is based on ultrasound, and after birth on clinical examination. Regarding treatment, it consists mostly of reconstructive surgery. Finally, neural tube defects are congenital anomalies that develop when a portion of the neural tube fails to close as it should during the 5th and 6th weeks of gestation. Prenatal diagnosis is based on specific ultrasound findings and high maternal serum alpha-fetoprotein levels. After birth, diagnosis is clinical. Treatment consists of surgery to close the opening wherever it might be.
Congenital adrenal hyperplasia is a disease where there are enlarged adrenal glands that are present at birth, and it can be caused by a number of enzyme deficiencies in the adrenal corticosteroid pathway. These enzyme deficiencies result in low levels of multiple adrenocorticosteroids, with cortisol always being one of them. Low levels of cortisol make the pituitary release more ACTH, which stimulates proliferation of adrenal cells, resulting in the enlargement or hyperplasia of the adrenal gland. Adrenal steroid hormone production takes place in the three layers of the adrenal cortex: the zona glomerulosa, where aldosterone synthesis takes place, the zona fasciculata, that's in charge of cortisol production, and finally, the zona reticularis is where androgens are made. Okay, now the first step for the synthesis of all three adrenal hormones is when cholesterol desmolase converts cholesterol to pregnenolone. In the zona glomerulosa, pregnenolone is first converted to progesterone with the help of 3-beta-hydroxysteroid dehydrogenase, or 3-beta-HSD. Progesterone becomes 11-deoxycorticosterone under the influence of 21-hydroxylase. 11-deoxycorticosterone becomes corticosterone with the help of 11-beta-hydroxylase. And finally, aldosterone synthase turns corticosterone into, well, aldosterone, what you'd expect. Some of the pregnenolone and progesterone can be used to make cortisol by making their way into the zona fasciculata. Here, 17-alpha-hydroxylase turns pregnenolone into 17-hydroxypregnenolone and turns progesterone into 17-hydroxyprogesterone. 17-hydroxypregnenolone is then also turned into 17-hydroxyprogesterone by the enzyme 3-beta-hydroxysteroid dehydrogenase. Then, all of the 17-hydroxyprogesterone is turned into 11-deoxycortisol by the same 21-hydroxylase enzyme, and 11-beta-hydroxylase makes 11-deoxycortisol become cortisol. Finally, some of the 17-hydroxypregnenolone and 17-hydroxyprogesterone are also used to make androgens. The enzyme 1720-lyase turns 17-hydroxypregnenolone into dehydroepiandrosterone and turns 17-hydroxyprogesterone into androstenedione. Dehydroepiandrosterone can also be turned into androstenedione by the same 3-beta-hydroxysteroid dehydrogenase enzyme. Both dehydroepiandrosterone and androstenedione can then be converted to testosterone. The most common enzyme deficiency is 21-hydroxylase deficiency. It causes over 90% of congenital adrenal hyperplasia cases, and it comes in two flavors: classic and non-classic. The classic form presents with symptoms in infants or young children, and it results in one of two clinical syndromes: a salt-losing form or a non-salt-losing or simple virilizing form. Both of these are caused by a genetic mutation on chromosome 6, but the simple virilizing form has only a cortisol deficiency, whereas the salt-wasting form has an aldosterone and cortisol deficiency. Non-classic 21-hydroxylase deficiency is even milder than the simple virilizing form, so it presents later in childhood, during adolescence, or in young adulthood. Now, in both classic and non-classic presentations, there are excess androgens which lead to different symptoms depending on genetic sex and age of presentation. With classic 21-hydroxylase deficiency, neonate girls have atypical genitalia, meaning an enlarged clitoris and sometimes a urogenital sinus, which is when the urethra and the vagina have the same opening. Partial or complete fusion of the labial folds may also occur. Internal female reproductive structures and organs, like the uterus and ovaries, are normal. Male infants usually have normal male external genitalia, but may have subtle findings such as hyperpigmentation of the scrotum or an enlarged phallus. With a salt-losing form, both male and female neonates can have a salt-losing adrenal crisis because of the aldosterone deficiency. This crisis is associated with hyponatremia, hyperkalemia, and a general failure to thrive. The simple virilizing form, on the other hand, does not lead to a salt-losing crisis, but can cause additional symptoms in male toddlers like early growth of pubic and axillary hair. Classic 21-hydroxylase deficiency is usually diagnosed at birth through neonatal screening. Additionally, a karyotype should be obtained in neonates with ambiguous external genitalia to confirm genetic sex. The screening test is performed a few days after birth, and a serum concentration of 17-hydroxyprogesterone above 1200 nanograms per milliliter is diagnostic of 21-hydroxylase deficiency. Bear in mind that if the mother received glucocorticoids during pregnancy, that can lower 17-hydroxyprogesterone levels, causing a false negative result. That's why if classic 21-hydroxylase deficiency is suspected, a negative test should be repeated 1 to 2 weeks later, while carefully monitoring salt loss in the meantime. Once the diagnosis is established, individuals with classic 21-hydroxylase deficiency require lifelong substitution treatment with glucocorticoids like hydrocortisone in a dose of 20 to 30 milligrams per meter squared per day, divided thrice daily. For example, newborns have a body surface of 0.25 meters squared on average, so their dose should be somewhere in between 4 and 6 milligrams per day, divided into 3 doses. Glucocorticoids inhibit pituitary adrenocorticotropic hormone, or ACTH, which prevents further hyperplasia of the adrenal glands and inhibits excess androgen synthesis. Older children and adults can be given prednisone or daily dexamethasone, preferably before bedtime. Additionally, all individuals with classic 21-hydroxylase deficiency should be started on mineralocorticoids like fludrocortisone along with sodium supplementation, with 1 to 3 grams of salt per day divided into several feedings, even if they don't have a clinically apparent salt-wasting form. Fludrocortisone doses typically need to be lowered after an infant is 1 year old because sensitivity to mineralocorticoid increases as the kidneys mature in the first year of life. Finally, affected females with classic 21-hydroxylase deficiency typically undergo reconstructive surgery, usually clitoroplasty and vaginoplasty. Response to therapy is monitored by periodic measurements of serum 17-hydroxyprogesterone with the goal of keeping it between 400 to 1200 nanograms per deciliter. Mineralocorticoid hormone status is assessed by blood pressure measurements and plasma renin activity, both of which should be in the normal range for age. High plasma renin activity correlated with high androstenedione reflects undertreatment, and fludrocortisone doses should be increased. Low plasma renin activity, on the other hand, reflects overtreatment, so fludrocortisone doses should be reduced. Additionally, growth velocity should be assessed at every visit. This represents how much the child has grown in height and weight since the last consult, and normal growth velocity charts can be used for comparison. Finally, glucocorticoid treatment can lead to premature closing of the epiphyseal plates and a short adult height. So the rate of skeletal maturation, or bone age, should be determined at least once a year after the age of 2, with an X-ray of the left wrist and hand. Advanced bone age is defined as a bone age that is more than 2 standard deviations below the mean, so a difference between bone age and chronological age of approximately 12 months between 2 and 4 years of chronological age, 18 months between 4 and 12 years, and 24 months after age 12. If bone age is advanced, glucocorticoid doses should be lowered. Now, on occasion, individuals with classic 21-hydroxylase deficiency can have an adrenal crisis due to physical stress, like illness, severe injury, or surgery, although this is typically rare after the introduction of neonatal screening. With an adrenal crisis, symptoms include hypotension or shock, vomiting, abdominal pain, fever, and mental status changes ranging from confusion to coma. There can be hypoglycemia and electrolyte imbalances as well. The first step in treatment is an IV bolus of 5% dextrose diluted in 0.9% saline at a dose of 20 milliliters per kilogram over 1 hour. Additionally, children should receive an immediate IV bolus of hydrocortisone, and doses here depend on age. Children younger than 3 should receive 25 milligrams, children between 3 and 12 should receive 50 milligrams, and children older than 12 should receive 100 milligrams of intravenous hydrocortisone. and then daily dosing thereafter. Hyperkalemia typically improves rapidly from the mineralocorticoid action of high-dose hydrocortisone, but if it persists, it can be corrected with glucose and insulin. Now, compared to classic 21-hydroxylase deficiency, non-classic 21-hydroxylase deficiency is milder. Affected females usually have typical female external genitalia at birth. The disease becomes apparent in adolescence when females develop primary amenorrhea or no menstruation by the age of 15, acne, hirsutism, and polycystic ovaries on account of excess adrenal androgens. Affected males may present with precocious puberty. A morning basal serum 17-hydroxyprogesterone over 200 nanograms per milliliter strongly suggests the diagnosis of non-classic 21-hydroxylase deficiency, and it can be confirmed with an ACTH stimulation test. This is when the individual is given 250 micrograms of cosyntropin, which is the synthetic analog of ACTH, and then serum 17-hydroxyprogesterone is measured again 1 hour after the injection. Values higher than 1500 nanograms per milliliter confirm non-classic 21-hydroxylase deficiency. Treatment is usually aimed at managing symptoms. Combined oral contraceptives can be used to ameliorate hirsutism and induce regular menses in females who do not desire pregnancy, and if it's not effective, then an anti-androgen medication like spironolactone can be given as well. If they wish to get pregnant and infertility is an issue, ovulation induction treatment should start with 5 milligrams of prednisone per day, and clomiphene citrate can be added if prednisone alone isn't sufficient. Affected males typically don't require any treatment. Now, individuals with non-classic 21-hydroxylase deficiency typically don't need stress doses of glucocorticoids, unless they're getting daily glucocorticoid therapy, which can suppress pituitary ACTH response to stress. Okay, now let's switch gears and look at the uncommon causes of congenital adrenal hyperplasia, or CAH, which account for less than 10% of the cases. First, there's 17-alpha hydroxylase deficiency, which leads to a cortisol and androgen deficiency and a buildup of 11-deoxycorticosterone and corticosterone. Elevated levels of these weaker versions of aldosterone result in hypernatremia, hypokalemia, and hypertension, as well as primary amenorrhea and sparse body hair in females, and undervirilization in males due to the cortisol and androgen deficiencies. The diagnosis is established based on having levels of 11-deoxycorticosterone above 100 micrograms per deciliter, levels of corticosterone above 4,000 nanograms per deciliter, and low levels of cortisol, androgens, and estrogen. Also, serum 17-hydroxyprogesterone is typically less than 0.2 nanograms per milliliter. Treatment relies on exogenous glucocorticoid replacement therapy with hydrocortisone or dexamethasone. Glucocorticoid replacement normalizes blood pressure, but that can sometimes take years. In the meantime, mineralocorticoid receptor blockade with spironolactone can help. Additionally, in females, development of secondary sex characteristics can be induced with low-dose estrogen given during puberty, and a progestin can be added 2 years later to induce cyclic menstrual bleeding. In males, testosterone therapy can promote development of secondary sexual characteristics. Another cause is 11-beta hydroxylase deficiency. This also leads to low cortisol, and while aldosterone levels are low, there's a buildup of 11-deoxycorticosterone, which has a weak mineralocorticoid activity and results in hypertension. Also, a lot of progesterone gets converted to excess dihydroepiandrosterone sulfate, causing virilization in females. So, 11-beta hydroxylase deficiency is a lot like 17-alpha hydroxylase deficiency, except it presents with androgen excess instead of androgen deficiency. Classically, female neonates have ambiguous genitalia, including clitoral enlargement and labioscrotal fusion, and male neonates may have an enlarged phallus. In children who are not diagnosed at birth, 11-beta hydroxylase deficiency presents as premature adrenarche with body odor and axillary and pubic hair development. The diagnosis is based on having high levels of 11-deoxycortisol, 11-deoxycorticosterone, dihydroepiandrosterone, and dihydroepiandrosterone sulfate, as well as testosterone. Individuals have low cortisol and corticosterone levels, and there's usually hypokalemia due to the mineralocorticoid excess. Children are generally treated only with hydrocortisone, whereas in adult females, spironolactone is also added to the treatment scheme. Spironolactone blocks both the mineralocorticoid and androgen receptors, so it controls both hypertension and signs of virilization. If pregnancy is not desired, oral contraceptives can be used in addition to spironolactone. In adult males, spironolactone may cause gynecomastia and sexual dysfunction, so it's contraindicated. But other drugs that block the mineralocorticoid receptor, like amiloride and triamterene, may be given instead. Finally, congenital adrenal hyperplasia can be the result of 3-beta-hydroxysteroid dehydrogenase deficiency. Try saying that one 3 times fast. This is a very rare disorder which results in deficiency of all adrenal hormones, cortisol, aldosterone, and androgens. The resulting ACTH excess leads to excessive production of 3-beta-hydroxy-delta-5 steroids like pregnenolone, 17-hydroxypregnenolone, and dehydroepiandrosterone. With 3-beta-hydroxysteroid dehydrogenase deficiency, both male and female infants are born with ambiguous external genitalia, so a karyotype should be done to confirm the genetic sex of the infant. Similar to 21-hydroxylase deficiency, infants have clinical manifestations of both cortisol and aldosterone deficiency, like feeding difficulties, failure to thrive, vomiting, hyponatremia, and hyperkalemia. Now, diagnosis of 3-beta-hydroxysteroid dehydrogenase deficiency is based on what distinguishes it from other congenital adrenal hyperplasias, which is the high ratio of delta-5 to delta-4 steroids in serum, especially after an ACTH stimulation test. So, a high ratio of delta-5 17-hydroxypregnenolone to delta-4 17-hydroxyprogesterone in the serum is characteristic for 3-beta-hydroxylase deficiency. Additionally, stimulated delta-5 17-hydroxypregnenolone values should be higher than 5,000 nanograms per deciliter to be consistent with a diagnosis. Treatment of 3-beta-hydroxysteroid dehydrogenase deficiency must include replacement of both adrenal and gonadal steroid deficiencies. In children, replacement doses of hydrocortisone and fludrocortisone are sufficient, with somewhat higher doses in females to prevent excess production of androgens from adrenal precursors. Additionally, sex hormone replacement therapy should be initiated at the expected time of puberty with estrogen and progesterone therapy in females and testosterone in males. Alright, as a quick recap. Congenital adrenal hyperplasia is most frequently because of 21-hydroxylase deficiency, which can be classic or non-classic. Classic 21-hydroxylase deficiency is screened for at birth, and a serum concentration of 17-hydroxyprogesterone above 1200 nanograms per deciliter is diagnostic of 21-hydroxylase deficiency. Lifelong substitution treatment with glucocorticoids is required, as well as mineralocorticoid replacement for the salt-losing forms. Non-classic 21-hydroxylase deficiency is usually diagnosed in adolescence, and serum 17-hydroxyprogesterone are higher than 200 nanograms per deciliter before ACTH stimulation, and can exceed 1500 nanograms per deciliter after ACTH stimulation. In females, combined oral contraceptives and spironolactone can be used to manage symptoms, whereas affected males typically don't require treatment. Uncommon enzyme deficiencies include 17-alpha hydroxylase, 11-beta hydroxylase, and 3-beta steroid dehydrogenase. With 17-alpha hydroxylase, there's high serum 11-deoxycorticosterone and corticosterone, and low serum 17-alpha hydroxyprogesterone, cortisol, androgens, and estrogen. Treatment relies on exogenous glucocorticoid replacement therapy. Secondary sex characteristic development can be promoted with estrogen and progesterone therapy in females and testosterone in males. With 11-beta hydroxylase deficiency, there's high 11-deoxycortisol, 11-deoxycorticosterone, dehydroepiandrosterone, and dehydroepiandrosterone sulfate, as well as testosterone, but low cortisol and corticosterone levels. We treat with glucocorticoids in children and mineralocorticoid receptor blockers in adults, spironolactone in females, and triamterene or amiloride in males. With 3-beta-hydroxysteroid dehydrogenase deficiency, after an ACTH stimulation test, there will be a high ratio of delta-5 17-hydroxypregnenolone to delta-4 17-hydroxyprogesterone in the serum, and delta-5 17-hydroxypregnenolone above 5,000 nanograms per deciliter. Treatment is glucocorticoid and mineralocorticoid hormone replacement in children and sex hormone replacement at the expected time of puberty.
With congenital adrenal hyperplasia, congenital means present from birth. Adrenals refers to the two adrenal glands that sit above the kidneys, and hyperplasia refers to increased cell proliferation, which leads to tissue growth. So congenital adrenal hyperplasia is a disease where there are enlarged adrenal glands that are present at birth. And the reason for the adrenal enlargement is that there's a deficiency in an enzyme involved with steroid production. Now, each adrenal gland has an inner layer called the medulla, and an outer layer called the cortex, which is subdivided into three more layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The outermost layer is the zona glomerulosa, and it's full of cells that make the hormone aldosterone. Now, the first step in aldosterone production is when an enzyme called cholesterol desmolase turns cholesterol into pregnenolone. Pregnenolone is the precursor to all of the adrenal cortex hormones, sometimes called the steroid hormones. Next, pregnenolone is turned into progesterone by the enzyme 3-beta-hydroxysteroid dehydrogenase. Then progesterone is turned into 11-deoxycorticosterone by the enzyme 21-hydroxylase. 11-deoxycorticosterone then gets turned into corticosterone by the enzyme 11-beta-hydroxylase. And finally, corticosterone is turned into aldosterone by the enzyme aldosterone synthase. So the final result is aldosterone, which is part of a hormone family called the renin-angiotensin-aldosterone system. Aldosterone signals the kidney to reabsorb more sodium into the blood and excrete more potassium. When sodium is reabsorbed, water also moves into the blood, which increases blood volume and blood pressure. The middle layer of the adrenal cortex is the zona fasciculata, and the cells there make the hormone cortisol. This process starts when pregnenolone and progesterone move into the zona fasciculata. There, the enzyme 17-alpha-hydroxylase turns pregnenolone into 17-hydroxypregnenolone, and turns progesterone into 17-hydroxyprogesterone. 17-hydroxypregnenolone is then turned into 17-hydroxyprogesterone by the enzyme 3-beta-hydroxysteroid dehydrogenase. Then all of the 17-hydroxyprogesterone is turned into 11-deoxycortisol by the enzyme 21-hydroxylase. 11-deoxycortisol is finally turned into cortisol by the enzyme 11-beta-hydroxylase. Now, cortisol is needed in times of emotional and physical stress, like arguing with a friend or fleeing from a pack of raccoons. In those situations, the hypothalamus, which is an almond-sized structure in the brain, releases corticotropin-releasing hormone, which acts on the pituitary gland, which is the pea-sized structure sitting just under the hypothalamus. In response, the pituitary gland sends out adrenocorticotropic hormone, or ACTH, which travels through the blood to the zona fasciculata of the adrenal glands and signals cells there to release cortisol. One of cortisol's main jobs is to increase blood glucose levels by promoting gluconeogenesis in the liver. This is the formation of glucose from non-carbohydrate sources, like amino acids or free fatty acids. Cortisol also gets the muscles to break down proteins into amino acids, and gets adipose tissues to break down fats into free fatty acids, both of which provide the liver with more raw materials to work with. The increase in glucose lets the body respond appropriately to those raccoons, or stressors. Finally, there's the innermost layer of the adrenal cortex, which is the zona reticularis. And cells there make a group of sex hormones called androgens. This process starts when 17-hydroxypregnenolone and 17-hydroxyprogesterone from the zona fasciculata move into the zona reticularis. The enzyme 17-20-lyase turns 17-hydroxypregnenolone into dehydroepiandrosterone and turns 17-hydroxyprogesterone into androstenedione. Dehydroepiandrosterone can also be turned into androstenedione by the enzyme 3-beta-hydroxysteroid dehydrogenase. Then androstenedione is turned into testosterone by the enzyme 17-beta-hydroxysteroid dehydrogenase. Alternatively, you can also get to testosterone by converting dehydroepiandrosterone to androstenediol first with the same enzyme, then using 3-beta-hydroxysteroid dehydrogenase to get to testosterone. The adrenal glands are involved in testosterone production in both men and women, but the amount that the adrenals contribute is pretty small in men compared to the testes. In men, testosterone is responsible for the development of male reproductive organs and secondary sex characteristics like voice changes and facial, underarm, and pubic hair. Since women don't have testes, they have relatively low levels of testosterone, but it's just enough to influence secondary sex characteristics like underarm and pubic hair. Congenital adrenal hyperplasia can be caused by a number of enzyme deficiencies in the adrenal corticosteroid pathway. These enzyme deficiencies result in low levels of multiple adrenocorticosteroids, with cortisol always being one of them. Low levels of cortisol triggers the pituitary to release more ACTH, which stimulates the cells in the adrenal gland to continually proliferate. This results in the enlargement or hyperplasia of the adrenal gland. The most common enzyme deficiency is 21-hydroxylase deficiency, which is found in both the zona glomerulosa and the zona fasciculata. In general, an enzyme deficiency will cause a buildup of the steroid before it in the pathway, and a decrease in the steroid that comes after it. Without 21-hydroxylase, the adrenal cortex is unable to produce both cortisol and aldosterone. A deficiency in cortisol causes hypoglycemia, and a lack of aldosterone results in loss of sodium and water in the urine and increased potassium in the blood. This is commonly referred to as salt wasting. When 17-hydroxyprogesterone and 17-hydroxypregnenolone fail to get used in the cortisol pathways, they get shunted into the zona reticularis and eventually become androgens. Since women normally have low levels of androgens, this increase is enough to cause masculinization of the female genitals and early development of secondary sex characteristics. The second most common enzyme deficiency in congenital adrenal hyperplasia is 11-beta-hydroxylase deficiency. Similarly to 21-hydroxylase deficiency, this condition results in decreased cortisol and aldosterone, as well as increased androgen production. 11-beta-hydroxylase deficiency, though, is distinguished from 21-hydroxylase deficiency by the presence of hypertension, which is caused by the buildup of 11-deoxycorticosterone. Since 11-deoxycorticosterone is an earlier version of aldosterone, it acts like a weaker version of it. And the large buildup of 11-deoxycorticosterone explains why there's hypertension despite the low levels of aldosterone. The third most common enzyme deficiency in congenital adrenal hyperplasia is 17-alpha-hydroxylase deficiency. This enzyme deficiency prevents pregnenolone and progesterone in the aldosterone pathway from being converted into 17-hydroxypregnenolone and 17-hydroxyprogesterone, which is needed in the corticosteroid pathway. When the levels of 17-hydroxypregnenolone and 17-hydroxyprogesterone are low, they also won't be able to get into the androgen pathway and become dehydroepiandrosterone and androstenedione. So this condition results in decreased cortisol and androgens, which causes poorly developed genitals and secondary sex characteristics in males, and a lack of secondary sex characteristics in females. Pregnenolone and progesterone are shunted down the aldosterone pathway, leading to a buildup of 11-deoxycorticosterone as well as corticosterone. Elevated levels of these weaker versions of aldosterone result in hypernatremia, hypokalemia, and hypertension. Even though the pathway is shunted to the aldosterone pathway, the levels of aldosterone is still surprisingly low. This is because the elevated blood pressure results in low levels of renin, which effectively shuts down the renin-angiotensin-aldosterone system. Symptoms of congenital adrenal hyperplasia depends on the enzyme deficiency. In 21-hydroxylase and 11-beta-hydroxylase deficiency, there's an increase in androgens, which causes masculinization of females. Changes include enlargement of the clitoris, acne, and hirsutism, which is the growth of facial and chest hair, and possibly even ambiguous genitalia. It could also cause early onset of puberty in females, and early appearance of pubic and axillary hair. On the flip side, in 17 alpha hydroxylase deficiency, there are low levels of androgens, so males might have ambiguous genitalia and undescended testes, while females might lack secondary sex characteristics like pubic and axillary hair. For the aldosterone pathway in 21-hydroxylase deficiency, there are decreased levels of steroids in the aldosterone pathway, which leads to salt wasting, particularly in infants, and can cause life-threatening vomiting, dehydration, and hypotension. In 11-beta-hydroxylase deficiency and 17-alpha-hydroxylase deficiency, there's an increase in earlier versions of aldosterone, which can cause hypertension. All three enzyme deficiencies result in low cortisol levels, which could lead to hypoglycemia. Congenital adrenal hyperplasia is normally diagnosed based on symptoms and blood and urine tests that can all help identify enzyme deficiencies in the adrenal corticosteroid synthesis pathway. In a lot of countries, including the United States, 21-hydroxylase deficiency is screened for at birth, and will show elevated levels of 17-hydroxyprogesterone if positive. Treatment of congenital adrenal hyperplasia often involves hormone therapy with cortisol, aldosterone, testosterone, or estrogen, depending on what hormones are deficient. Cortisol in particular helps to suppress ACTH levels via negative feedback, and therefore prevents further hyperplasia of the adrenal glands. Early surgical correction of the genitals is also sometimes recommended. Alright, as a quick recap. Congenital adrenal hyperplasia is an overgrowth of the adrenal glands present at birth, and is caused by a deficiency of various enzymes in the steroid synthesis pathway of the adrenal cortex. The most common type is 21-hydroxylase deficiency, which usually presents as masculinization in women and salt wasting and hypoglycemia.